Hello everyone and welcome back to my channel. For those of you who do not know me, I am now a second year PA student at MBKU in Fullerton, California, and I just finished up my first rotation in emergency medicine. I have an Instagram at White Coat Chasing where I post more kind of my daily life in my rotations, but I also have another YouTube video about my emergency medicine rotation. I'm going to do this Q&A and then I'm going to do one recap of kind of like emergency medicine, my rotation as a whole. And I'm going to be trying to do that for each of my rotations. So this is my very first rotation, so this is my very first like Q&A video. So I just asked on my Instagram what kind of questions you had for just in general emergency medicine rotation. So that's what I'm going to do today, is just answer some of your questions. But before we get started, don't forget to follow my Instagram, like I said, at White Coat Chasing, and then subscribe to this channel for more videos about my rotations to come. All right, so I have all of your questions all right here from Instagram. So the first question I'm going to answer is, how did you prepare? And so for my emergency medicine rotation, since it was my first one, I kind of got to know that I was doing it earlier than other rotations. So how it works for my schools, we usually find out our next rotation about 2 weeks before we start the rotation. So it's not too much of like notice in advance. But for this one, we got to know about like a month in advance, so I had a little bit more time. I mostly just listen to podcasts. I listen to there's like an EM clerkship podcast. I kind of just listened to a lot of like emergency medicine related things. I didn't necessarily do a lot of book studying because I didn't want to kind of burn myself out before I went and started. So the podcasts were a great way to study and then also kind of be engaged in like the conversation between emergency medicine providers. So I will probably link some of the podcasts that I checked out before I started in like the description box, because I can't remember all the names on the top of my head right now, but the podcasts were absolutely amazing. So that's kind of mostly what I did to prepare. And then the rest of like the book studying, I did more during my actual rotation. All right, so next somebody asked, what is a typical day like working in emergency medicine? So I worked both day and night shifts, and where I worked, it seemed to be a little bit different than like any other emergency department I've talked to my friends about, which I'm sure every emergency department is different. But for the first like hour and a half of your shift, you're outside. So we had a tent right now because of COVID. So it'd be outside like triaging patients. So the first like hour and a half, you'd pick up like 10 to 15 patients that you would actually follow for the rest of the night, or for at least for half the night. So you go in for an hour and a half, pick up your patients. So you would, get the interview, do all of that physical exam, and then you'd order the labs that you need to order. And then it would be taken into the hospital to wait for those labs and whatnot. So then after you got your like 15 patients and your hour and a half was done, you would go inside and you would follow up on those labs, discharge people as appropriate, do the procedures you need, like laceration repairs and stuff like that, and wait for more labs and then admit people. And about mid-shift, you go out to the tent again, triage and get 10 to 15 more patients, and then do the same thing until the end of your shift. So I know everywhere does it a little bit differently. So just for the first hour and a half of my shift, I would be with a preceptor. I'd be seeing, some patients on my own. I would get the stories. I'd present it to my preceptor, say what I'd like to order, and then the plan and all of that. And then that would just go on for an hour and a half. Then when we get inside is when I would start helping with like procedures, when I would go and like educate the patients, to tell the patients like the labs, like the results of the labs and stuff like that. So it was kind of just a little flow of seeing patients, and then for a few hours you're kind of waiting for things to come back, talking to patients, patient education, stuff like that, and then going back and interviewing more patients and whatnot. So my night shifts were from 6 p.m. to 4 a.m. And then the day shifts that I worked were like usually about 9:30 to 7:30. So they were 10 hours, so it wasn't too bad. But my drive was like 45 minutes at the best. It got to 2.5 hours, but average was like an hour, 15 minutes for me, because it was considered one of my away rotations. So it was a bit of a drive, so it made the day kind of longer, but the shifts themselves went by pretty fast, especially because mid-shift you were back seeing patients and doing more like hands-on stuff. So it went by pretty fast, but that was basically my day in emergency medicine. All right, somebody asked, how did I prepare for like procedures like lacerations, rectals, pelvic exams? So you learn like all of those things in school. Our school had like real like standardized patients who we did pelvic and rectal exams on. So I had done at least one on a human. Obviously it wasn't a patient, that's a bit different dynamic, but I at least had done one. And so the PAs that I was with were really, really helpful. They usually they did one, it's a whole saying, you know, see one, do one, teach one. So that's basically what I did. I saw them do it, and then I went in and did it, and then after that they trusted me with it. The pelvic exams, they were always there, but the rectal exams, after I had done one and they like were comfortable with me, I would just get a chaperone and I'd go and do them by myself, and I do the little like guaiac card, which shows if there's any blood in the stool. Then laceration repairs, same thing. The first one that I had was on a hand. The PA that I was with through the first 2 sutures, and I did the rest of the 3. And then from that point on, any laceration repairs that I had or that we encountered during our day or night, I did by myself. So they saw the patient initially, made sure that there was something that they felt comfortable that I could handle, and asked me if I was comfortable with it. And after my first one, I was totally fine with it. So then they would say, okay, do this. And then I just asked them, okay, do you think like 4-0 sutures good or 5-0? Just ask them a couple questions and what they thought, how they thought I should best go about it. And then they would just set me free, and I'd suture them up, and then they'd come and check it afterwards. And then I'd bandage them up, and then I'd just, put them out for discharge. So I didn't really prepare ahead of time aside from what I learned in school. And you just kind of learn right there on the fly. They teach you the first one or throw the first 2 sutures, and then you're up and you gotta just kind of do it. And it's a little scary at first and a little nerve-wracking, but your school should prepare you for it, and you should feel a little bit at least decently comfortable, especially after they show you one time. And they're always usually pretty open about like if you have any questions, or if you don't feel comfortable doing something, or if you can ask them, hey, can you just throw one more stitch just so I can like see how you did it, and then go from there. But never tell them no to doing something unless you're genuinely very uncomfortable or you don't feel like it's safe for you or the patient. But if they're asking you to, hey, you want to try this, and they feel comfortable doing that, always at least try and ask questions if you don't feel like you're doing it right in the time, in the moment. Or if they set you free to go do a laceration repair and you feel like this one's just a little bit different than the other ones you've done, do not feel afraid to go back to your preceptor and say, hey, you know what, actually, I would love to have your input on this, or can you just help me figure out how to do this? Like even one time, one of the cuts had a little bit of a V in it, and I wasn't quite sure how to like align it properly. And I asked my preceptor, and she's like, yeah, I can probably just do like right there and right there. And I was like, okay. And then I did it, and it was fine. So definitely ask questions if you don't feel comfortable. So this next question was, did you have any experiences with high acuity patients, such as like codes, trauma, and STEMIs? So I feel like our hospital was a stroke center, and it also had a cath lab, but it wasn't a trauma center. So I didn't see too many traumas. I did see some codes. I didn't really participate in any of them because I only saw a couple, and they were like pretty rough codes. And then STEMIs, I actually helped like work up some of the STEMIs, or like saw some of the patients were there and they ended up having STEMIs. It wasn't too many. We had a couple come in like ambulance STEMIs, and that was usually the doctors that handled that. So I like had some experience with it, but like not too much. I did have one code that was really bad, and I'll talk about it when I answer another question. So a lot of my experiences with like those types of things was more watching, because the PA or the preceptor that I was with was never directly involved in those codes. It just happened to be that way. It's not that they can't be involved. It just happened that they weren't their patient to get involved. So I had a lot of more hands-off shadowing experience in those situations, but I didn't really have too many hands-on experiences in those high acuity experiences. All right, so the next question was, how was your experience with updating patient charts, and did the providers guide you? So I actually did not do any charting this rotation. We had scribes, so the scribes actually charted for us, which is funny because they're always like joking that like you'll never get a scribe, or yes, you never get a scribe as a student, and then I got a scribe as a student. And we weren't really allowed to order anything or add anything on the note, and I don't think that was just like site specific, because I know a lot of other rotations have you do the like the chart. If that was something that I was able to do, I would have felt comfortable with doing it. I was a scribe before, and I kind of understood what was necessary and what wasn't necessary, and I was comfortable asking them questions if like I needed to at that point. But that's just something that we didn't do at this rotation, and that's okay. It was nice to be able to practice like my interviewing skills and physical skills and stuff without like having the stress of charting. And I'm lucky that I have experience as a scribe, so like even if I don't get as many charting experiences during rotations, I've already had like a year or so of that background, so I have like that to build on, if that makes sense. So yeah, no charting in this rotation. Okay, this next question is, have your thoughts changed about emergency medicine as you experienced it? Has it changed for the better or for the worse? So when I found out I got this rotation, not only was it an away rotation and kind of an interesting community, but it was also emergency medicine, which I have no experience in. All of the patient care experience I've had has been like a slow paced, kind of more outpatient environment, or just like family medicine or at a nursing home. So nothing like high acuity or stressful really in terms of like that emergency medicine type of stressful. So I was very, very nervous, thought I would not like it. I went in and it started off great. Like I liked my experience, but there was just certain things about it that really I was like, I don't connect with this. You know, I really like continuity of care and like being able to like follow a patient through and through. So at the beginning I was kind of like, yeah, this really isn't for me. And then as my shifts went on, now I'm not saying I can see myself really in emergency medicine, but as my shifts went on, I started to really like it and like really appreciate certain things of emergency medicine that like I know that's why people become emergency medicine providers. Like, you know, having a patient come in, figuring out if they're sick or not, and if they're not sick, discharging them. So I know that's like, to me that's like, it's a pro and con. Like it's really cool because you're able to like make sure they're not dying of anything acutely, and then you send them home and like somebody else will figure the rest out. That's kind of nice because they're out of your hair, you don't have to do any more digging. But on the other side, I really like being able to follow through and order more labs and have them go get an MRI done or have them go do this, and like figuring out what's wrong and making them feel better, because so many times they leave the emergency room just not feeling any better. You know, you give them pain medicine to mask it for like the few days, but they have to go follow up with primary care to get better testing. And so it's like, I can see both sides, but I think having a, you know, family medicine scribing background and like nursing home and stuff like that, and following up, you know, with patients daily and continuity of care, I'm used to that and I've become comfortable with that. But I can also see the other side of things and how great that can be. So I think my thoughts about emergency medicine has definitely gotten better. I'm not as scared of it anymore. It isn't completely off of my list of things I would want to do in the future. I wouldn't want to work where I was rotating at. That's just, that emergency medicine, that emergency room just seems crazy. And even the providers at work, they know that it's a crazy one. So I'm sure maybe down the line, I can see myself at a different emergency room, maybe in a less hectic place. All right, so this next question is most interesting case or patient experience. And I talked about this on my story because it was hard. So it was one of my day shifts. It was my first day shift actually. And I was working with this PA who was so sweet. Absolutely so sweet. And it was kind of a slow morning. Nothing was really going on. And all of a sudden, like, we had someone with a head bleed and we were like suturing her lip, and like we got her out for she had to be transferred via plane, so we were kind of dealing with that. And all of a sudden there was like a code going on, there's a lot of commotion, and my preceptor was like, you can go ahead and watch, this is probably going to be an interesting one. And so it was a baby, and I didn't really get any of the history. I just know that she was kind of like having difficulty, I think just like breathing for not too long. Anyways, I didn't really get that side of it. I didn't get to see the workup, but all of a sudden they were helping this baby and she was responsive and it was fine. But they just said she was a little bit off. Like when they went to put the IV in her, she didn't really like fuss as much as like a baby should. So then they put her on the cardiac monitor and she was in VTAC. And things from there just went so south. They quickly had to intubate her, and they were giving her like, they like pulled out, I've never seen it before, but like a pediatric on the crash cart, there's like a paper, and it like measures how long they are, and then it correlates to a color, and then that color correlates to like a drawer in the pediatric crash cart. And then that's all like where the supplies are that are necessary for the medications and all of that, for that code. So like it was just absolutely hectic. There was like 15 people just like running around. This baby went from, she looked fine, she was with her mom, mom was holding her, to basically just being like intubated, and people pushing medication into her, and people just panicking and freaking out, and her being okay, and then them getting, you know, the air flight to transfer her to another hospital, and then it was okay for a minute, and then it went downhill again. It was just so hard to see. Codes are hard to see no matter what, but codes on a baby, I had never had any experience with seeing any children being sick or any children getting, you know, I'd never seen that before. And that was already very traumatizing to see. And and I have to be careful with what I say because there's a lot of HIPAA and I don't want to like say anything that I'm not supposed to. That's why like I try not, when I tell patient stories and when I'm talking about it, I try to like leave so much out so that everyone's protected, including myself and my school and all of that. But so they had no idea what was going on. They had no idea what was causing this. They had no idea. There wasn't much of a history. They were asking if she could have possibly gotten to somebody's like stuff at home or like what this could possibly be, and just there was no answers. They were trying to draw blood and we're not able to like draw enough blood to be able to like get labs run to see if any electrolytes were abnormal to like fix those. It was just a lot of not knowing what was like the root of the problem, and a lot of just it got bad. And then towards the end, finally the flight crew came and they were trying to stabilize her enough to be able to transfer her to somewhere where they had like a higher level of care. And then at that point she was in PEA, which is pulseless electrical activity, and so they were doing CPR on her, and they had been doing CPR this whole time with like a defibrillation. But about 5 minutes after the flight crew got there and was also administering their medications, she passed away. And that was definitely the hardest thing. It was like one thing where it was very, obviously it's very sad to see a baby die, but it didn't really hit hard until I saw them tell the mom that the baby didn't make it. And those screams are something that I will have just burned into my mind for the rest of my life. That was definitely the hardest moment I've like ever had in medicine, and that is probably selfish of me to even say because I don't feel anything nearly what that family felt. But after seeing that, I tried so hard to keep it together and I couldn't. I walked away from the family. I was outside and I started bawling. And my preceptor saw me and she came over and she gave me a really big hug and told me to just go take a few minutes, take a deep breath. She's like, go get Starbucks if you need to or something, just breathe. Call someone if you need to, talk it out, because I was really rough. But I sat for a little bit, breathed, stopped crying, and then just went about the day. But that was probably the craziest patient interaction I've had. And I wasn't even interacting. But I feel like even by shadowing, and even pre-PAs when you're shadowing, you still learn so much by observing. And obviously in that moment, I wasn't necessarily learning medicine. Also, although they were pushing medications, I was kind of learning all about that and like how to run a code, pediatrics and stuff. But watching people, like observing people and how they interacted with a family and how, they walked them through that and explained things to them and everything. That side of it was so valuable to watch, and I'm very thankful that I was able to be a fly on the wall and to observe that. But that was definitely the hardest patient interaction that I have ever seen. All right, on to the next question is, did you work closely with techs? I'm an EMT on a rig and want to work in an ED to see a PA in action. And yes, I did. I worked really closely with the techs. They were the ones obviously that would do like all of the stuff outside in terms of like helping patients get to like lab and splinting and ACE-RAP and yada, yada, yada. So a lot of it was when the patients were waiting for certain things, I would go and interact with the techs a lot and ask them like, hey, is it okay if you do this? Or, hey, can you help me set up this? Or can you chaperone with me for this rectal exam? So I actually interacted with them quite a bit, and they got to see a lot of what the PAs do. So I think that's such a great role. The ED techs, they did so much and got so much interaction with phlebotomists and nurses and PAs and doctors and stuff. I would really recommend an ED tech as a PCE, like a position before starting PA school. I also got to chat with a lot of EMTs and paramedics because they would bring in the patient to like the ambulance bay, and then I'd get the full history from them. I'd ask them questions. They kind of like, just said what was going on, and they're so helpful. They're like presentation skills. Obviously they've been doing this for a long time, but like I aspire to have their presentation skills because they are so efficient and have all of this knowledge just like ready to go when they get in there. So it was really cool working with them. And the first time I ever saw my own patient, like for the first day, it was a lady who came in via the ambulance, and I had to elicit the full history, get a physical exam, do all of that in front of like 2 EMTs, 1 paramedic, the PA was a PA that I was my preceptor, and then like a nurse. So I had a whole audience, including the patient and the patient's granddaughter. So that was kind of stressful to have all of that for my first patient. But it was really cool, and they're all super nice and like really understanding and really helpful. So not only did I work with ED techs, but I also worked with a lot of EMTs. All right, so another question is, for PA school, does it require you to go through an ER rotation? And yes, it is one of your core rotations, so you will have an emergency medicine rotation no matter what PA school you go to. All right, next question is tips for overcoming discomfort with suturing lacerations. So it really helps to have a good preceptor for your first one to help walk you through it. Even just like going and grabbing supplies, knowing what sutures to use. So it's something that you can study beforehand, is what sutures do they use, where, and how long do they stay in, which is really important for patient education to like let them know when they should come back and get those removed if they are non-absorbing sutures. So get comfortable with like those materials first. If you have a suture kit at home, practice holding everything. That was like really helpful to have had that experience and have done that quite a bit, so I didn't feel like I was stumbling around with the needle and the, and all of that. So I felt comfortable with that, and it was just the fact of like getting over doing into an actual human instead of like a little suture pad. But if you have a preceptor that kind of helps and walk you through it, that is super helpful. They should do that typically, at least for the first time, no matter what. Some preceptors may throw you out to the woods, and that's when practicing beforehand is really important. But typically, I feel like a lot of them are at least helpful for the first time that you do it. And then after that, they might just send you out to the woods. But just you're more comfortable with it when you're talking to the patient and like explaining what's going on, and they feel comfortable. Because I feel like for me, when I was explaining to the patient what was going on and was explaining what I was going to do, I felt more comfortable and more confident because I knew what I was talking about. They felt comfortable with me explaining it to them, so I felt just more confident in myself talking it out. If some patients don't like that, that's okay. You just kind of go about your thing and don't chat. But I actually, every single person that I sutured up, I ended up having like a full-blown conversation about their life. And like one lady, I like basically gave life like therapy to. And I recommended, I was like, I think you should follow up with therapy, because I'm not licensed to do any of that. But I had a great conversation with you. So I think just getting to know the patient, talking to them, chatting with them, finding some similarities and kind of running from there. So when you're doing your suture and it takes a little while because you're slow as a student, it's not awkward. But I think just having the preceptor there, asking questions if you need to for your first few ones, knowing where to find everything so you're not running around. I think those are like the huge, like really big important things to starting to feel comfortable doing them. And then once you do a couple, you're like, yeah, okay, I got this. Like one of the docs was like, hey, have you done like laceration repairs before? I was like, yeah, I've done a few. And he's like, how many? And I was like, 6 now. And he's like, okay, good. So I have a guy in bed too right there, cut his head, you got to suture him up, yada yada. Should be 3 on each side, just use 5-0 and you're good. I'm like, okay. And he like hadn't seen me work before at all because it wasn't my preceptor. He just like let me off to suture this guy's face, felt comfortable with it. I like asked him to check it when I was done. He's like, yeah, sounds good. So I think once you do like a couple, you start feeling like super comfortable and confident. And like I said in another question, if you have any questions or this laceration is just bigger or just more irregular or something's just not right or you don't feel comfortable with something, always ask your preceptor for help and they should be willing to help you. All right, so this is a good question. How did you manage the flow or the craziness of the emergency department if you didn't have this experience in patient care experience, so like your experience before PA school? And then did I ever feel overwhelmed or like over my head? So of course, when you're a student, no matter what, the first thing you do, especially your first rotation, that you'll always feel like you're in over your head. You'll always feel like you're overwhelmed, or unexperienced, or like just a lot of people feel like they shouldn't be there. Whatever the feeling may be, I feel like that's always a big thing, especially for your first rotation, is what I've heard from other people too. And then for me, I've never had emergency medicine experience, so I was like, this is a lot. I don't know how I'm gonna do this. But you just kind of have to take it just day by day. The first day, you kind of shadow a bit more, so which is really nice to kind of get the flow of the thing, get an idea of how things are run. And it's chaotic. The emergency medicine is chaotic. You'll have people come in that are yelling at you. You'll have people on drugs that are yelling at you. You have people bugging out in the corner. You'll have people throwing up everywhere. It's chaotic. You'll be trying to do a patient like history and someone over here is like coughing up their right lung and like it's a lot. But I think you just have to have it, like, take it, like, not even just day by day, but like patient by patient. Like, if a provider tells you, hey, go see that patient, don't worry about anybody else right there. Worrying about that patient, their chief complaint, and the questions that you need to ask, figure those out, do the physical exam, and then get back to your preceptor and present to them. And if you miss something, that's okay. You can go back and ask them again. And you just focus on that one patient. Make sure you get your history told to your preceptor as best as you can. And then, okay, you're done with that patient. Breathe. Now you can put in orders or have the provider put in orders and then move on to the next patient. And then when I was doing that, like just kind of focusing on one thing at a time, my day went by so much faster because I wasn't worried about all the craziness that was going on. I wasn't worried about the person in the corner yelling or all these crazy things. You just kind of focus on one thing at a time and you kind of just get through your day. And after a while, like once you get comfortable with the environment, you get comfortable, kind of know where everything is in the emergency department, you don't feel like a little lost puppy. You can kind of sit back and absorb all the craziness happening and kind of just watch it go on. And you get really familiar with it very, very fast. Within like the first week, I was, when I first walked in, there was like people lining the halls, and I was like, this is insane. This is so, like, I was very overwhelmed. My first day, just seeing the amount of people and the amount of nurses running around, and then having people come in from the ambulance bay, and then have like EMTs. It was like, I had never even stepped foot in an emergency room before this, let alone playing PA. But you really quickly get used to your like role as a student and how much you can help and things that you observe, and you kind of just get used to that role, and everything else, it just is normal. It feels, you just get very used to it quickly is all I can say. So this question was, what is one thing you did not expect to learn that emergency medicine PAs do? And I couldn't think of anything like specific, but I guess how I can answer this best is every time I've talked to somebody who's had like emergency medicine experience, whether it's like a scribe or ED tech, has always talked about like the different level that PAs practice at each facility. So the facility I'm in is an underserved location, and it's like a very small emergency department. I guess it's not super small because I know there's like really rural, teeny tiny ones, but this is like, I guess, a medium-ish size, but it is in a rural area, and it's a very interesting patient population. But here they utilize PAs to like their full extent of their license. So some emergency medicine, like emergency rooms, will have PAs just do like fast track things, which are like coughs and colds and kind of like more of the simple things, UTIs, kind of stuff like that. Whereas like all of the like chest pain and like shortness of breath and stuff like that, patients will be only seen by physicians. So at this emergency department, PAs see like all levels. So in the daytime, usually the ambulances or kind of like the big codes or traumas or anything like that are handled more by the doctors, but the people who like check themselves into the emergency room in the tent, the PAs will see whatever people are checked in there during that 1 hour and a half time that I was describing earlier. So if people come in with chest pain or shortness of breath or possible PE or heart attack or something, that PA is working them up. They're not being sent to a doctor. And that's not saying that PAs take cases that they're not like supposed to have, or that PAs take cases that are unsafe for them to have. They always have doctors in the hospital like ready to consult, or if they feel like they can't handle that case, they will, transfer it to the other provider, to a physician. But PAs there work up all of these higher acuity kind of like complaints, like I said, like shortness of breath or chest pain and stuff like that. So some other emergency departments, PAs don't do that. They don't really see those like possible like higher acuity cases. So I really liked being able to rotate in an emergency room where PAs are able to work up all of those types of complaints. That was really cool to see. And I think that if I ever wanted to go into emergency medicine, which it's lower on my list, but not completely cut off my list of where I would potentially work, I would love to work somewhere that does utilize their PAs to the full extent of their license, because I think that's really awesome, and what a waste to have PAs not being able to do that, you know what I mean? So although that didn't really answer the question fully, I think my perceived like notion of what PAs do in emergency rooms was like a little bit different than what I actually got to experience. I thought they didn't do as much of the high acuity stuff, but when I came here, they were seeing all the same patients that a physician would see if they were in that hour and a half window. So that was pretty cool to see. All right, just a couple more. So this next question was, what has been your least favorite part about your EM rotation? So I kind of talked about it before, but I think my least favorite part about emergency medicine is that there's kind of like no continuity of care. So for example, we had a patient come in and they had abdominal pain, and we ended up having to admit them. and they were in severe pain, and we had given them pain medicine when we had like initially triaged them. But as soon as they were admitted, they're under like the hospitalist care. So at that point, the PA that I was with is not their provider, so they can't order anything for them. So they can tell the hospitalist like kind of what's going on, but beyond that, they can't really do anything about that patient anymore. And what sucks is like these patients will wait hours in the emergency room waiting for a bed to be able to be admitted into the hospital. So it's like I would walk past this patient multiple times when like going to like talk to other patients, and she was in pain, and they kept asking me like, can she please get pain medication? Can she please get pain medication? And I had to explain every time that like the PA that I was with that saw her cannot prescribe her anything at that point, cannot give her anything because she's under the hospitalist care. And we are informing the hospitalist, but like at that point in time, the hospitalist did not have time to go and see this patient or prescribe them anything. So I think just like that was like a huge moment of showing me like the continuity of care is just that's not a thing in emergency medicine. And that's why a lot of people in emergency medicine go into emergency medicine, because they don't like having to see the same people and over and having to do patient education and have the patient completely ignore you and then be back for the same exact thing like a week later. So I think that's the one thing that people in EM like love about that, where I love to see them again. Like I think that's because of my family medicine background, where I got to see how they were doing, or if that medication worked for them, or if they were, they went through PT and they're still in pain, so now they're going to get an MRI, and then they're going to go get surgery and stuff like that. I kind of like being able to see that progression. So I think that was the one thing about emergency medicine that just really frustrated me, was seeing patients that are in pain or that had all these questions that just were not answered. And the best thing I can come up to them is saying like, we only check for things where we're really acutely worried about, things like heart attack, stroke, big things like that. And if we're not having that right now, it's not really life-threatening. And then you follow up with your primary care and go for further testing. Like that was the best education I can give them, was like, you're not dying right now. Sure, you're in probably a heck of a lot of pain. We can't really do anything besides a few like pain medications that we gave to you. Go follow up with primary care and figure it out there, because we're not going to do anything else. So like I get like both sides of it, but I think that was probably one of the most frustrating things about emergency medicine for me. Somebody asked, were you the only student for your preceptor? If not, how did you all share responsibilities? So yes, our preceptor like wasn't one person. It changed every single day. We just worked with like whatever PA worked on that shift. So I didn't have the same preceptor for like more than 2 days, which was fine. It was fun. You get to work with different personalities and stuff. So I really liked that. But if you're working with a PA, you are the only student that was working with them at a time. And typically, so their shifts were like kind of like stacked. So like I talked about an hour and a half in the tent. So the PA would have like an hour and a half in a tent, and then they'd be outside, and then they'd come in and they have the student there. And then the next PA would come in with their student, and they would be like an hour and a half in the tent. So you wouldn't have too much overlap. So other PAs had students the same day I would be there. Maximum, there was only 3 of us ever at one time, but that was only for like an hour and a half. And then that other student was off, and then we came in later. So max was ever like 3 students on at one time, but you're all kind of in different places. So it wasn't super overwhelming. And all of your responsibilities are with the patient that are with the patients that your provider sees, that the preceptor that you're with that day that they see. So if you and your preceptor see like 3 lacerations and 1 like abscess, you would be responsible with your preceptor to get those laceration repairs and the I&D done for that patient. So then the other student, even if they were there at the same time, whoever like the patients that they saw together, they would take care of them. So it's kind of cool. You have like basically separate days. So you got to see, and I interacted with a couple of them sometimes, and we did like 1 patient history together, but that was like about it. But other than that, you're pretty much completely separated from your other students. And it's not that they do this on purpose, it's just you are kind of handling different things at different points in time, if that makes sense. All right, so someone said, not a question, but wow, feels like just yesterday I saw you post about your first ER day. And I'm not kidding you guys, this rotation went by so fast. Our rotations are 6 weeks, and a couple of students I worked with, their rotations are only 4 weeks. So like if 6 weeks went by fast, I can only imagine like what only 4 weeks would feel like. You like just start getting comfortable, and all of a sudden you only have like a week left, and then you're gone. It's crazy. It went by absolutely fast. I was not that I was dreading it, but I was like, oh, okay, I can do this. It's like, I didn't know my shifts at that point when I first heard about this rotation. I was like, okay, maximum 5 days a week. That's okay. I can do it. Maximum 5 days a week. And it's a long drive, but it's okay. I'll get through it. And then like 2 weeks in, I was like, okay, wait, I'm actually kind of enjoying this. The drive still kind of sucks. Very interesting patient population, but I'm like, okay, this isn't too bad. And then like by like week 4, I was like, okay, I'm actually enjoying this. I'm really enjoying the procedures that I get to do. I'm like getting to know the nurses and chatting with them. The scribes, I like got to know so many of the scribes and like their like goals in life. And like I had such a good conversation with one of them and like about like his journey to medical school. And then I had a really good conversation with like another girl, and we talked about like astrology, and she like taught me about my sign and stuff. So I got to get really close with a lot of the people there. And then after like, it was like week 5, and I was like, oh my God, wait, I only have a few days left. And it was really sad. And I was sick for one of the days, so I had to give him one less day than I would have had. So by the end of the 6 weeks, I was really enjoying it. It wasn't like a chore to go. I was having fun. I was excited for the procedures that would come that day. So it flew by fast, and I'm so thankful to have all of you here along with my journey and share my journey on Instagram. I post a lot more stories there about like kind of my day to day and like what I get to see every day. And I will do, like I said, another video talking more about the actual like the procedures that I did, the different cases I saw, what like chief complaints I worked at most. So that video will be coming out a little bit later. I'm gonna have to like edit this one, and then Christmas is in a couple days, so that's gonna be chaotic. So I'm hopefully gonna get that done on this break. But that will go more in depth about kind of like the actual medicine that I did. This was more kind of Q&A to see what you guys all wanted to hear about in rotations, especially it being your first one. I feel like it's really fun to share my experience in my first rotation because everyone has rotation jitters. I feel like for each rotation you'll have rotation jitters, but like nothing will compare to your first one. So it wasn't bad. Overall, I'll talk more about it in my other video, but overall, I'm telling you guys, it's really fun. This is your only time to be able to mess up. Obviously, I'm not saying mess up and hurt anybody or risk anybody's life, but you can make a mistake and it's okay. You have a lot of protection from your preceptor. You have so many people that you can ask so many questions, and they expect you to ask questions and they want you to ask questions. So this is such a safe space for you to learn and really take advantage of it. If you're a PA student going into your emergency medicine rotation soon, or just into rotations in general soon, you're gonna have so much fun. It's so nice not to be studying every single day and to see the connection between these diseases you learn and actually seeing patients with these diseases. That helps you learn like nothing else. So rotations are a great time. You're gonna do great. If you're starting emergency medicine rotation soon, you are gonna do awesome. Have so much fun with the procedures. Ask to do everything that they would allow you to do. Be proactive. Get up, help. Get a warm blanket if you have to get a warm blanket every now and then. Ask other providers, hey, do you have any laceration repairs that I can do? Just jump out to on any opportunities that you can have during your emergency medicine rotation, and you will do great. And don't be nervous. There's some people that I know that have never had emergency medicine experience, and they all really enjoy it. And if you're just proactive and ask questions and are responsive and coachable and teachable, you will have an absolute amazing rotation. But all right, so that is enough of me gabbering. If you have any more questions, you can always DM me on my Instagram at whitecoatchasing, or you can leave a comment on this video down below, and I will try to get back to you as soon as possible. But thank you so much for watching. I really appreciate it. I hope you watch my other rotation videos. I have like a little playlist of like my rotation videos, and as more and more start coming, I will be adding more videos. So I only have one before this one, and then I will be filming my kind of like overall review on my rotation, kind of like how to help you prepare, what things I think you need to know before you go into your rotation, like what apps I used, all of that fun stuff, what procedures I did, all of that stuff will be in that video. So look forward for that coming out hopefully soon. But again, thank you so much for watching, and I hope you have a great day.